welcome everyone. Thank you so much for joining us. We're a little bit late. We don't know what happened to the Zoom login details, but we are here. I've got Dr. Vikas, and who's going to be joined by Dr. Mansi all the way from India, and they'll be joined by Chiona Woolford all the way from Maryland. Thank you so much for everybody who's joined us. If it's okay, you can put on the cameras, or if you're not comfortable, it's fine. So my name is Agnes. I'm the founder and the executive director of Australian Sickle Cell Advocacy, and we are doing this on behalf of our organization, just continuing to raise awareness. And we do this by virtual education sessions and interviews mostly because we in this pandemic together, and we just thought, what can we do to sort of play our role in terms of raising awareness for sickle cell. So as I said, Dr. Vikas before, I will quickly just do a presentation, tiny bit, why we are doing this about our organization. Then we're going to go into your presentation. We have so many questions that we have for you, and Tiona too has got some questions. But how are you this morning, this afternoon in India, before I just talk about us so much?
Hi, so thank you for inviting us, Agnes, and me and Dr. Mansi. We both are pediatric hematologists, oncologists, and bone marrow transplant physicians, and working in a hospital called Fortis Memorial Research Institute, Gurgaon. So we are in the capital. So Delhi is the capital of the country, and we are working in the capital. And right now it's 1:30 p.m. and we all are affected with this COVID pandemic, and the number of patients who are coming to the hospitals are less. I don't know whether the disease has gone down, or is it the people who are actually scared of coming to the hospital. That's the reason. So we actually don't know, but we are also trying to cope up with this pandemic, and hopefully all of us will come out of this.
Yes, definitely. Well, thank you. And Tiona, welcome, my friend. How are you this morning?
Hi, I'm doing fine. Thank you for having me.
Thank you. So I'll just quickly do a quick presentation. I'll be very quick because we have run out of time. The most important thing today is for us to listen from Dr. Vikas, who's going to give a presentation about bone marrow transplant and sickle cell disease. So who we are, as I said, we are doing this on behalf of Australian Sickle Cell Advocacy. We are the umbrella organization in Australia to raise awareness about sickle cell disease. And we started off in 2014, and we've got a lot of members on social media, over now almost 9,000 people following us different social media platforms. We are run by a board, and our board's interim chairperson is Dr. Margaret Evans-Scalia, AM, and we've got other scientists and doctors, hematologists on our team, and our chapters across all Australia, which are run by the executive committees and committee members. Our mission is and values really just to raise awareness, and we do this making sure that you are following our values, which are excellence, perseverance, integrity, and caring. And the objectives are divided into 4. We are raising awareness, providing education sessions like this and information, supporting people who are affected, and advocating for more research in sickle cell disease. And why we're doing this, for us, we've realized that there's a need to do this because of the numbers of people that are potentially affected by sickle cell, who might be affected by sickle cell disease. They may have a sickle cell trait, but you also have experts are saying we have about 1,000 people living with sickle cell disease in Australia, and that's why we continue doing this. And finally, I just want to say that Dr. Vikas will be giving a presentation, bone marrow transplant in sickle cell disease, for raising our awareness purposes only. He won't be giving medical advice. If you've got any questions, any specific questions, please direct them to your GP or hematologist. He can answer general questions only, but not specific questions. If you don't have any GP or hematologist, please contact us and we'll be able to connect you with one anywhere in the world. So thank you so much. Before we start the session, I told Dr. Vikas that we like asking questions, just how you came into practicing what you're doing now. And so I'll just ask you a few questions. Then we go into our final presentation.
Sure.
So this topic today, for me, is very personal. For most people, I've been talking about this over and over again. My daughter had a bone marrow transplant just over 18 months ago. She was born with sickle cell disease, diagnosed with sickle cell anemia at 14 months. And we did everything in the sickle cell treatment until we agreed to have a bone marrow transplant just over 18 months ago. And so this is very close to my heart. So before Dr. Vikas does the presentation, I'll just tell you that Dr. Vikas is a pediatric oncologist and bone marrow transplant specialist in the generation. Dr. Gio's results in the field of pediatric hematology, oncology, and BMT have been some of the best. He and his team has done over 350 pediatric transplants. He's known for his excellent work in stem cell transplant, especially in pediatric haploidentical transplant. He has done some of the rare transplants which nobody else has done in India. So we were to hear that from Dr. Vikas. So bone marrow transplant, as we know, for those people that have sickle cell disease and just general, at this point in bone marrow transplant or stem cell transplant is a cure, the only cure known for sickle cell disease. However, as we've read, there's so many barriers, including having a donor, especially in Australia. We have to have a sibling donor who's 100% match. But also there's barriers to treatment options, which could be other side effects that Dr. Vikas will go through. And just other areas that I want Dr. Vikas to actually explain. There is gene therapy options that are going on at the moment, but the only known cure at the moment is a bone marrow transplant, and that's why this is very important to us. So, Dr. Vikas, before we go into detail, we just want to know, like, how did you come about specializing in sickle cell disease? Did you know anything in sickle cell disease when you're growing up?
All right. Thank you, Agnes, and I would really like to thank you for inviting us and giving us this opportunity, this platform to be here with you and giving a talk on a very interesting topic, which is bone marrow transplant in sickle cell disease. So all of us, uh, that as we speak on 10th August 2020, the only permanent cure for sickle cell anemia is a bone marrow transplant. Rest all is experimental. I think all of us have to understand that. So
Yes.
talking about my interest in sickle cell, so I'm a pediatric hematologist, oncologist, and a bone marrow transplant physician. So those of you who are listening to us, let me tell you about myself and my colleague, Dr. Mansi. So we both are trained in pediatric hematology, oncology, and transplants. That means we look after kids who have blood disorders from day one of life to 18 years of age, whether it is a benign blood disorder or it's a liquid tumor like leukemias. We look after patients who have solid tumors till the age of 18 years, and we do pediatric bone marrow transplants. I did my fellowship and training, most of the training from India, and then I moved to Singapore. I did my transplant fellowship from National University Hospital Singapore, and my colleague Dr. Mansi, she's a board certified pediatric hemato-oncologist and has done her hemong training from Hershey, and then she did her bone marrow transplant fellowship from St. Jude Children's Hospital, Memphis. So in India, so coming to your question, so in India we don't see a lot of sickle cell anemia patients because in India there is a specific belt, there is a specific zone where you find sickle cell patients. That's called Chhattisgarh. That's on the eastern side of India. But there are a lot of patients from Africa. All of you who are listening to us must be knowing this thing that Nigeria is the sickle cell capital of the world, and not each and every part of Africa is being affected by sickle cell, but there are countries like Nigeria, Uganda, Zambia, some parts of Kenya, Tanzania, Cameroon, Congo, and I mean Ghana. These are some of the countries from where people travel to us for opinion and for bone marrow transplant. The reason these people come to India is that India has become, I would say, is a choice for medical tourism. People prefer to come to India because the cost of transplant in India is much less as compared to West. So in India, if you ask me, the cost of a match sibling donor transplant might be 10 times less what people quote in US or in UK. That's why these people from Africa, they prefer to travel to India for a bone marrow transplant. And so when I started my career in pediatric hemong, almost 10 years back, which was almost 10 years back. So the when I started my career in pediatric hemo and bone marrow transplants 10 years back. So we started doing transplants, and people were coming to us from different parts of Africa, and that's how I developed interest. And then I started following up these patients, and we started doing 6 monthly camps and OPDs in different parts of Africa, and that's how I developed interest. And then when I had completed almost 20-25 transplants, we gained more experience. 20-25 transplants in sickle cell, I would say, we gained more and more experience, and then we were able to understand the pathophysiology and in depth about transplant in sickle cell, and that's how we developed interest. And now we have done more than 50 transplants for patients of sickle cell, mainly from Nigeria, Uganda, and Zambia. I can't hear you, Agnes. You need to unmute.
Thank you. You said sickle cell is not so common in India. What statistics are we looking at, and what part of India did you say again?
So there's a specific, there are specific, you know that sickle cell runs in, it's a genetic problem. It runs in tribes. So there are certain parts which is called Chhattisgarh. So there's a state on the eastern part of the map which is called Chhattisgarh. So that is the place where you see a lot of sickle cell anemia patients. Other than that, there are a few states like I would say Madhya Pradesh, Maharashtra, and Gujarat. But we are sitting in the capital. We are in Delhi, so we hardly find sickle cell patients over here. So majority of patients who come to us for treatment are from these states or from Africa.
Okay. Okay. And
same thing there in US and in your part of the world also, that you don't find sickle cell over there. It's because of the African people who have migrated to Australia. You're seeing. Yeah.
Okay. Yeah, but we've got some cases in India, right? And because it's genetic, at this point with migration, we might say, anybody's at risk, right? To raise awareness, right? And
Yes,
do you yourself know whether you carry the sickle cell gene or not?
Yeah, we know it. We know it very well. So before marriage or before conception, because so as we all know that Nigeria is the sickle cell capital of the world. India is thalassemia capital of the world. It's another hemoglobin. It's another hemoglobinopathy like sickle cell. So in India, we do see a lot of patients who have thalassemia. So it's a mandate that we do HPLC before marriage or before conception of the mother. And if mother is a carrier, then we check the father also. So it's very important for us to understand that these three you need to do preconceptional screening, I would say, for people, so that you can come to know your thalassemia status or your sickle cell status. So in our country we do HPLCs. So in HPLCs you can come to know whether the patient is normal or a thal trait or a sickle trait.
Okay, great. So how are you doing this? I want you now to go into detail to talk about our topic today. Are you doing a presentation? Do you need me to give you the sharing power to share the screen, or are you just going to talk about it?
I don't have a PPT, a PowerPoint presentation, but I can talk about sickle cell if you want, or we can start with the questions from your side. Whatever is comfortable to you guys, we can do that. If you want me to talk in general about sickle cell, you want me to tell about transplant, now I can do that. Or I would be more than happy if you start asking questions to me. Me and Mansi would be more than happy to answer that.
Okay, so I think at this point, we might not be able to ask some of the questions. I'll give you maybe 15 minutes just to talk generally, sickle cell disease and bone marrow transplant. And from there now, we are going to go into a Q&A. Yeah.
So I invite my colleague, Dr. Mansi. So she's going to tell you about what sickle cell anemia is all about, how these patients present, and what are the treatment options which are there for sickle cell, and what is the role of bone marrow transplant. And let her start, and then I'll add things to that.
Okay, great. Thank you, Dr. Mansi.
Hi everyone, I'm Dr. Mansi Sachdev, and I think they've already given my introduction, so I'm just going to talk about a little bit about sickle cell and what are the signs and symptoms and what are the treatments that are available to a patient who's suffering from sickle cell disease. So to start with, as Dr. Vikas has already mentioned, and you guys already know, that sickle cell is a genetic disorder where your red cells are sickle shaped. So the patient who's suffering from sickle cell disease has certain signs and symptoms that they manifest. Even if you don't know, if you know about these signs and symptoms, then it will be easier to pick these patients up. So as early as 6 months of age, some of these patients do show some signs and symptoms, and majority of these signs and symptoms are because of these sickle shaped red cells. They get clogged. So your blood vessels become clogged with these cells, and you get these symptoms. So as early as 6 months of age, you have a small child who has swelling of the hands and feet, and is irritable, is crying, is in pain. That's called, in medical terms, it's called dactylitis. But basically what is happening is that your joints are getting swollen, your small hands and feet are getting, the blood vessels are getting clogged, and you're getting these signs and symptoms. So if you have a very small child who's irritable, who is crying, who has a little bit of fever, does not look well, I mean, that could be just the first sign of somebody having sickle cell disease. Other than that, in general, you can have acute chest syndrome, you can have acute pain crisis, you can have aches and pains in the body, you can have stroke. Again, all these symptoms are because of the abnormally shaped red cells. You can have, sometimes you don't know, but like retinopathy or nephropathy, meaning that you can have visual impairment because your blood vessels are getting clogged. You can have some kidney disorder because of all these things. So these are in general some of the signs and symptoms that these patients can have. They can have leg ulcers, they can have priapism. All these things can happen in sickle cell disease. Now, what we're talking about is sickle cell anemia. We're not talking about sickle cell trait. Now, what is important to know is that sickle cell trait patients, I mean, I won't even call them patients because they live a normal, healthy life.
Yes,
So in
yes.
general, they will not know that they have sickle cell trait. It's only, majority of the times, I would say, it's only when we have a baby or our child who's been diagnosed with sickle cell anemia. In retrospect, when we do the analysis of the parents, that's when we get to know that yes, mother and father were both traits, but because they were so healthy, they were living a normal, healthy life, nobody thought of doing that test on them. So that's what
Hmm.
Dr. Vikas was saying, that it's very, very important when you are thinking of starting a family or getting married. If you have not done earlier, it's always better to do hemoglobin electrophoresis, and the other name is HPLC, to find out if you are a carrier of sickle cell disease or not, the sickle cell trait. Because if the mother or a pregnant lady who has sickle cell trait, it is very, very important to get the father tested as well, because we know that 50% of the genes come from mother and 50% of the genes come from father. So when you're having a baby, there is a 25% chance that both are, if your mother and the father are both traits, there is a 25% chance that the baby can have sickle cell disease. And we're talking about, so 1 in 4 chance. So if you had a baby, so say if the first baby had sickle cell disease and now you're expecting the second baby, I'm not saying that the second baby is not going to have sickle cell disease. You have to remember it's a chance. So it's a 25% chance in each pregnancy that you can have a sickle cell anemia baby. So that is very important that you have to keep in mind. So that's about prevention. Now, let's talk about treatment. Now, in general, like we have already discussed today that we're talking about, bone marrow transplant is the only available cure for sickle cell disease. Now, there are medicines that can help these patients to alleviate the signs and symptoms that they have. There's a medicine called hydroxyurea, there's a medicine called L-glutamine. So these are the medicines that are going to help decrease the signs and symptoms of these patients, but it's not going to cure the sickle cell that you already have. So today, on the 10th of August 2020, the only available treatment or cure for sickle cell anemia is bone marrow transplant. Yes, you talked about gene therapy. Gene therapy is upcoming, and it will be wonderful to see, like maybe in the next 5 or 10 years, hopefully, fingers crossed, we will have that available to all of us, to all the sickle cell patients, and it will be like, it will be great for sickle cell patients. But today it is still undergoing a trial phase. So we are not there yet, but hopefully we'll be there soon.
Yep.
So let's talk about why we do a bone marrow transplant in these patients. Now, we have already talked about that this is a genetic disease. So what we really want to do in layman language is that we want to eradicate the abnormal hemoglobin that is there in the body with a healthy hemoglobin. So how we do it is that we give some medicines to the patient. We give what is called chemotherapy to kind of empty their bone marrow so that we can give normal, healthy donors bone marrow to these patients or stem cells to these patients. And what really is going to happen is, by God's grace, fingers crossed, if everything goes well, is that the normal donor cells are then going to start multiplying and forming normal red cells. So a sickle cell patient is going to be cured of the sickle cell, but what we have to also remember is what has already happened because of sickle cell is not going to go away. So we are just going to prevent the progression. So for example, if I have to give you, say if there is a patient who's had a stroke and has a right-sided weakness, right-sided body weakness, we cannot cure that by transplant. But yes, it should not progress and he should not have another stroke is what we are looking at. So that is very important for patients to understand as well.
Yeah, I think that's the most important thing. What all of us who are listening to us need to understand, earlier the better. So if you have an end organ damage, if you have a problem, if your organ function is disturbed, if you have a complication which has happened because of sickle cell, you may not be able to cure that. So it is always important to do a transplant early in the life rather than waiting for a long time.
Okay.
And also sometimes, if I may add that, I have been trained in Pennsylvania, and we did see a lot of sickle cell disease patients there, but also depends on whom you talk to. Like if you talk to a
Yep.
transplanter, they are pro transplant. But if you talk to a pure hematologist, they're kind of, I mean, for lack of a better word, I won't say they're scared, but they believe in giving hydroxyurea, they believe in giving L-glutamine. They're a little bit hesitant on telling the patients to go, and I don't know why, but they're a little bit hesitant to tell the patient that yes, this can cure you. So also the other message is that even if you are seeing a hematologist, please go and talk to a bone marrow transplant physician who might be able to tell you what is new in the field and might be able to tell you
Okay.
what's good and bad about transplant as well. Because it all depends on whom you're talking to.
Okay, can I just come in there? I think at this point, I would like to bring in Tiona. So I advertised that you're going to come in, Tiona, because Tiona has had the first-hand experience with having a bone marrow transplant. I won't say much. I'll just bring in Tiona, introduce yourself, and just tell us how you are affected or how you experience having a bone marrow transplant. Thanks, Tiona.
Okay, hi guys. So I actually had a bone marrow transplant 8 years ago. And when I had it, my quality of life just wasn't what I wanted to do. Like it just wasn't where I wanted to be, and I felt like my body was constantly failing me and all of this. And I was in a very like my mental state was not good. I was depressed. So I went in for a consult, and by the time I left the room, I really kind of felt like I didn't have a choice. Like I was told that if I didn't have it, I was going to die. And I just felt like I didn't have a choice, and I was super desperate. So I went and I had it, and long story short, I rejected, and my bone marrow stayed shut down for like 5 months. So I was in the hospital the whole time. And my hematologist wants me to consider doing it again, but mentally I can't get there. And I did have another consult at another institution, and they really kind of said that it wasn't even an option because they only do second transplants in people who have had some percentage of chimerism. And is 0 for me. I didn't have any. It didn't take at all. So I just had a couple questions for you guys that I think, like as more people pursue these curative therapies, I think it's important to have open, honest conversations so that everyone can make an informed decision. And, you know, the community is kind of split on transplants from what I've seen. There are some people who are really scared, really mistrusting, and they don't want to even talk about it. And then there are some people in the community who almost approach it as if it's like a standard of care, and all I have to do is get this transplant, my whole life is going to change, which is what I thought when I did it. So I had some questions for you, and I wanted to ask you first about the eligibility criteria. I know like 8 years ago when I was considering it, they didn't do people who had any organ damage. There was an age cutoff. You had to have a support system. It was a lot of requirements. So I just wanted to talk to you guys about what your eligibility criteria is.
Thank you. Okay, so before Mansi answers that, let me tell you, it's very, very important what you're talking about. It's very important for the families to understand. So we all know that transplant is the permanent cure, but the families need to understand the goods and bads. The pros and cons have to be explained to the family in detail, because God forbid you land up in a mess. You see a mortality. You have you lose the patient, and then if the family is, I would say, is not accepting that, so that time it's very depressing, I would say, and that time is not good for the families and for the doctor also. I think it's very, very important for the families to understand these things very, very clearly. We What we do in our practice, we have 2 3 consults. So whenever somebody comes to us for a transplant, even if that baby is fully matching with the sibling, we are doing a match sibling donor transplant, then we have at least 2 to 3 years. So we tell them very clearly in a crystal clear way the pros and cons of a transplant, and then we ask them to go home. We tell them to go home, come back after 2 3 days, and come up with your questions. We ask them to take in a note, take bring it in black and white. You write down whatever is coming to your mind and come up after 2 3 days with those questions, so that once you understand it clearly, then only we are going to go ahead with the transplant, otherwise not. So, and both father and mother have to agree to that. If one of them is not agreeable with this thing, then we don't do a transplant. So that's very important. Now coming to the indications, so in some centers in the West, in US, they say that as the disease free survival, overall survival is more than 95 to 98% with a massive donor transplant, you should do transplant in each and every patient of sickle cell, whether he's symptomatic or not. But if you ask us, in our practice in India, we follow specific guidelines. We follow certain indications for doing a transplant, which Dr. Mansi is going to tell you.
Okay.
Thank you.
So Tiona, thank you so much for sharing your experience. I'm sure that people would learn a lot from all the things that we are talking about today. So coming to your question of what do we look at, or what are the indications of doing a transplant in a patient who has sickle cell, and especially we are talking about match sibling donor transplant here. So there are specific indications or specific things that we ask for in terms of the patient has been suffering from these or had this in the past. So having a stroke, that becomes an indication of transplant, because we know the sickle cell patients are at risk for having strokes. If you have acute chest syndrome with recurrent hospitalizations in the past year or so, or having recurrent veno-occlusive crisis, having at least 2 or 3 per year. So what all this does to you is your quality of life really is not where it needs to be. And that's why we are talking about transplanting these patients, right? We want to prevent that end organ damage that can happen from the sickle cells. Because if we have a patient who already has an end organ damage done to the body, that's not good. That kind of takes away from us doing a successful transplant. We don't want that, for sure. So if somebody is having impaired neuropsychological function, if somebody is having recurrent priapism, there's also something called sickle lung disease, there is nephropathy, there is retinopathy, if there's osteonecrosis of the joints, and that's a well-known complication from sickle cell anemia. All these are indications for doing a transplant in a patient who has sickle cell disease.
That's right. And to add on to this, if you have red cell alloimmunization, if your red cells are breaking down and your red cell aluminized, you're requiring multiple recurrent blood transfusions, that's another indication. If you have pulmonary hypertension, if the patient has got pulmonary hypertension, that's another indication. So please understand these things. Stroke or a neurological deficit which has been there in the child, at least 2 episodes of chest syndrome in last 2 years, around 3 episodes of pain crisis in last 2 years, retinopathies. These are relative indications, I would say, retinopathies, nephropathy, and AVNs. But if you have red cell aluminization and pulmonary hypertension, and these are certain indications for which a transplant is required.
So what we're talking about is like,
I was just about to tell you that some of the terms, because we don't have medical people on the panel, if you can just break it down a little bit so that they can understand what exactly you are talking about. Thank you.
So stroke meaning you have injury to the brain from the sickle cell itself. So you have like a blood clot in the vessels in the brain. So you have like a hemiparesis, or like you have paralysis of one side of the body. That's called a stroke. If you have that, so that's one. Otherwise, if you have aches and pains in the joints, in the muscles, or if you have chest syndrome, by chest syndrome we mean that you're requiring oxygen, you have fever, you have cough, you have chest pain. That's what is acute chest syndrome. So you have all these symptoms and you are multiply going to the hospital and getting admitted, you're getting oxygen, you're getting IV antibiotics, you're getting IV medicines to reduce your fever. You do an X-ray and there is like a pneumonia patch. So that's what is called acute chest syndrome. So just to elaborate on that, if you have kidney injury, so either you're having some blood in the urine, or you're losing some proteins in the urine, or you're having some swelling of your body, you need to get your kidney function test done. And if it's due to sickle cell disease, that becomes another indication for transplant. And then say somebody is having a lot of pain in the joints, especially say if it's the shoulder or if it's the hip joint, and you do an X-ray and you see the head of your shoulder is not to be seen, or there's a shrinkage of your bone. That's kind of what is called osteonecrosis. So that is another indication for bone marrow transplant.
Okay.
Okay, I just have one more question. So I actually worked with the American Society of Hematology to put out transplant guidelines. And one of the things that we discussed was kind of what you guys already talked about, like what is the appropriate age to do a transplant? And I think medically we all agreed that the earlier the better, but mentally we had some challenges because it's hard to explain to a 6-year-old the gruesome process that they're about to go through. And I know that children are incredibly resilient, but for me as a 19-year-old adult, the toll that it took mentally, like I was aware of a lot of the physical complications, but I wasn't at all prepared for what it would do to my state of mind and how depressing and how dark it could get. So what do you guys do to kind of address that whole mental state of the children and of their parents to really prepare them psychologically for what they're going to go through?
All right. So we do involve our psychologist sometimes, because after discussing with the families, after having 2-3 meetings with the families, means both the parents, if they're accepting the facts, and if we feel that they are ready to go about it, and they are accepting the goods and bads of a transplant, then it's okay. But there are times when you feel, when the transplant physician feels that we need to involve the psychologist at that point of time, we try to involve the psychologist. We do have a adult and a pediatric psychologist in our hospital, and then we make the family sit with the psychologist and discuss in detail about that. And once the psychologists give us an answer whether the family is ready or not, then only we go ahead. Otherwise we don't.
All right. Can I just ask, like, what's the process? And coming into our experience, for us, for after we finally accepted that our daughter was going to have a transplant, it took about a year in terms of preparation. Firstly, we do all the tests to check whether the organs are strong enough, all the tests that you do, and including the psychological part as well, where we saw the psychologist for a while, not just ourselves, but our daughter as well and the siblings. So what's the process for you once you've agreed, that yes, we are going to do this transplant? How do you prepare the person just to check whether their body is strong enough to undergo such an aggressive, risky treatment?
So when we take up somebody for transplant, we have to do what is called a transplant workup. So basically, we need to go from head to toe to make sure that all the organs are working well, that the body will be able to tolerate such kind of treatment, because that's very important. So, we do the usual tests, looking at the CBCs, the complete blood count, looking at the liver function, your kidney function, whether they are working well or not, because we know with sickle cell, the kidneys could be affected. We also do what is called a lung test, which is a pulmonary function test. We sometimes have to do a CT scan of the chest and the sinuses as well, to find out if there are any kind of infections that are there, or if the underlying lung is healthy or not. We do what is called a DTPA, which is basically a dye test for the kidneys, to find out how the kidneys are functioning, because some of the medicines are dosed depending on how well your kidneys are functioning. Um, yeah, and then urine tests. So these are the different kind of tests, just to make sure from head to toe that everything is working well.
Yeah,
Okay.
and definitely it all depends what type of problem you had in the past. Like if we have a patient who had a stroke in the past, we would like to do a MRI of the brain. So MRI brain, a patient who had chest syndromes in the past, definitely we would like to see the status of the lung, because if we are using a conditioning called busulfan based conditioning, busulfan is toxic to the lungs. So we need to understand what is exactly happening with the patient, and then only we can choose the conditioning regimen.
Okay. Well, thank you for that. So we have about 10 minutes. Now, I'll ask you, are you okay to continue on with this session? Because we have so many people on the panel. I'm sure they do have questions. Are you okay to continue on for a bit?
Sure, please go ahead. Yeah.
All right, thank you. So for people joining us on Facebook, we have Dr. Vikas and Dr. Mansi, all the way from India, giving a session on bone marrow transplant. And we've got people on the panelists. So maybe at this point, before we put into the Q&A questions, maybe you can answer. You did talk about the kind of conditioning that you do. And for people who don't know, conditioning is the kind of chemo that you use to do the transplant. Can you explain further and what sort of conditioning you do and why you choose a specific conditioning for individual patients?
So for a matched sibling donor transplant, the commonest conditioning, what is being used throughout the world, is called busulfan with cyclophosphamide based conditioning. So these are chemotherapeutic agents. So busulfan and cyclophosphamide is a chemotherapeutic agent. So these are myeloablative conditioning regimens. So these medicines are going to suppress your marrow. It is going to empty your marrow. It is I would say, a strong, in layman term, if I have to say, I would say it's a very strong chemotherapeutic agent, which is going to empty your marrow, your hemoglobin, your white cells, your platelets are going to go down. And you add another agent called ATG, anti-thymocyte globulin, because there was a time when people were just using busulfan with cyclophosphamide, and they were seeing a lot of patients not engrafting. They were absorbing a lot of graft failures. But when they started adding ATG to the regimen, they found that the graft failure rates went down. So a standard practice, what we do and majority of the centers in the world do, is using a myeloablative conditioning with busulfan cyclophosphamide with anti-thymocyte globulin. But nowadays, people are trying with RIC conditioning, like reduced intensity conditioning. In that, the commonest regimen is fludarabine with melphalan. Fludarabine with melphalan, and some people are combining that with alemtuzumab. The problem with that, there's not much experience with RIC conditioning, but the good thing of RIC conditioning is that it is not a myeloablative conditioning, so you may not see acute and late toxicities. You may see less, I would say less of acute and late toxicities with rig conditioning. But the flip side of that is, the bad side of that is that you may not engraft. That might
Mm.
not be a sufficient conditioning to empty your marrow, and you may not accept the donor cells.
And that's when the rejection comes in, right?
That's right.
Yeah. Okay. So people on the panel, if you've got questions, just let me know. But I still have a few questions that we received beforehand. So how long does the treatment likely? So everybody has accepted. How long does it take once now the first day they come in hospital? What happens then?
So the first time that they come to the hospital, we sit with them, we counsel them, like we've already said. We give them some time to process, what we're going to do, what's there in their mind, what they had thought, and what we are saying. And if they have any questions, all that said and done, once they decide that yes, we're going to go ahead with the transplant, and say if we admit somebody, say today, the conditioning is about 8 odd days long, 8 to 9 days. And day 0 is when we actually give the stem cell infusion to the patient. So from then, we would say approximately it would take anywhere from 2 to 3 weeks for the stem cells to start kind of multiplying and growing inside the new body. So in general, we say once we admit a patient, it takes anywhere from 3 to 4 weeks. If everything goes as planned and we are not seeing any complications, the patient engrafts, meaning that the red cell, the stem cells have started to work, the white count has risen, the hemoglobin is okay, the platelets are okay, the patient is doing well. So it takes anywhere from 3 to 4 weeks. And it all depends on, what we find during the time. If you have any complications, if you have a fever or an infection, that might be a little bit more prolonged stay. But in general, it's about 3 to 4 weeks, we would say. So if somebody is coming to us from outside, or say not from India or not local, then we usually say that they have to be in India for at least the first 100 days, because that is the time that we see majority of the complications as well. Once we have discharged somebody from the hospital, say after 4 weeks, we see them very frequently in our outpatient practice to make sure that they're doing well, to find out there are any complications or not. And it's probably, every other day for the first couple of weeks, because they're still very fresh from transplant. We want to know what's going on. We want to know if there are any complications. And then if the patient is doing well, we kind of space out the visits a little bit.
Okay, thank you. We'll continue on that, but I've just got a question here. Somebody's saying if somebody, if a person is successful on hydroxyurea, is it necessary to consider a bone marrow transplant, and what is the rate of success of the transplant?
I think it's very important for all of us to understand that hydroxyurea is not the permanent cure.
Not a cure, right?
Hydroxyurea can take care of the problems. So it can increase your HbF level, and it can decrease the chances of complications like pain crisis, stroke, chest syndromes. But that's not a permanent cure. And we need to understand that you can have complications with hydroxyurea as well. You can have myelosuppression, you may have alopecia, you may have sexual dysfunction with the use of hydroxyurea. But if somebody is doing well, so it's important for the family, it's important for us and family to sit together to understand the pros and cons of a transplant and of hydroxyurea, and then we leave to the family to decide what they want.
Okay. The other question they had was if your siblings also have sickle cell anemia, do you accept donors from outside the family?
So actually, you brought out a very good question, because we've had a lot of patients who or parents who ask us this question. Actually, I just want to highlight that even if we have a donor, like say if we have a match sibling who is a thalassemia trait, that donor can be a donor. I mean, that sibling could be a donor for the sickle cell patient.
Okay. As long as they match. Okay.
Yeah. So yeah, as long as there's a match in the family, we have a sibling who is a full match. If the donor has sickle cell trait, then that can be a donor for the patient. Because at the end of the day, what we are trying to do is we're going to take away all the signs and symptoms that are happening because of sickle cell anemia. So what is going to happen? The patient is going to become sickle cell trait and is going to lead a normal, healthy life, like anybody with sickle cell trait would live. Now, the
Okay.
other question that you're asking is, if we don't have a suitable donor in the family, can we take an outside donor? The answer is yes. We
Okay.
can take a match unrelated donor, and there are registries for it. The problem is, sickle cell usually happens in African descent or African Americans. So the distribution, I would say the ethnic distribution of patients, and because the donors are not so many, we don't find so many matched unrelated donors in the registry. So recently, they had come out with the data that African descent, if you look at how many donors are available in the registry, is only like 15 to 20%. So only 15 to 20% of patients who are from this ethnicity are going to find a matched unrelated donor. So that is not encouraging. I mean, what I mean, like the donors are not limited.
That's very important for everybody to understand, and that is you need to have people from African origin in the registries. So the biggest registry in the world is called NMDP. So a survey was done some years ago, and it showed that patients who are from African origin, or you can say whether it is African American or directly coming from Africa,
Yeah.
for them to find a donor, a full match 8 by 8 or a 10 by 10 donor, the probability of that was just 16%. Probability of getting a 7 by 8 donor was 67% in that survey. So that's not good enough. So you need to have more people of your ethnicity to come up for donation, so that those people who need a transplant and unfortunately don't have a full match sibling in the family, for them it would be easier for us to get a donor from outside if the number of donors increase.
I wanted to ask you guys, I'm just out of curiosity, what do you guys have fertility preservation options built into your protocol?
Yes, we do, and we
Okay.
actually do counsel all our, especially teenagers, um, to undergo that. We actually have an open discussion with the family and with them, that we do advise that they do undergo fertility preservation, and we do have preservation happening in our hospital itself. So
Okay.
there are doctors who actually meet with them, and they undergo extensive counseling, and whatever needs to be done. And the majority of our patients actually do that, and then
Mm-hmm.
only for
But we leave it
transplant.
to the families and
Correct.
to the patients to decide. So if it's a boy who's going to go ahead with the transplant, we ask them to, if there's an option of sperm preservation, if he wants that, we have that in house. And if it's a female, then definitely option of ova preservation is there.
Okay.
And
Mm-hmm.
then we leave it for the families to decide.
All right. Thank you.
Okay.
Now, can you talk about the side effects and how you treat some of the common side effects you've seen in your treatment, like graft versus host disease? How do you treat that if it comes up in the treatment?
Yeah, so graft versus host disease is, I won't say one of the dreaded, but it's something that we don't want to see, but unfortunately we do see. It's graft versus host disease, as the name suggests, that some of the donor cells react with the patient's body, and it can have some signs and symptoms, like if it affects your gastrointestinal system, you can have some nausea, vomiting, diarrhea. If it affects your skin, you can have some rashes. And if it affects your liver, you can have some kind of jaundice, or your liver function can be deranged. If that happens, first we know that when we are doing a transplant, that's always a possibility that can happen. So we give medicines to prevent it. So it's called GVHD prophylaxis. So there are some medicines that these patients get to begin with. But if unfortunately some patients do have GVHD, then we treat it with medicines itself. And the first line medication for GVHD is steroids. And we start usually with IV steroids, and depending on the response, if we have to add more things, we do. But I would say majority of the patients do respond well to steroids itself.
That's right. I think prophylaxis is very important. So even if it's a match sibling donor transplant, we give immunosuppressive medicines in the form of cyclosporin, tacrolimus, sirolimus, methotrexate. So these are certain immunosuppressive medicines which the patient gets as prophylaxis. But if somebody develops on GVHD, even after getting the prophylaxis medicine, then the first line therapy is steroids. And it depends, if somebody has got a skin GVHD, then you may be able to control that in some cases with local application of steroids. Certain patients require oral prednisolone, but those patients who have got liver GVHD or gut GVHD, they may warrant intravenous or IV methylprednisolone. But there are few patients who are steroid refractory, those who don't respond to steroids. For them, there are a lot of medicines which have come up. I don't think this is the right platform to discuss that. But you have medicines which can be used in steroid refractory GVHD. But other than GVHD, there are few more complications which can happen. That's what Dr. Mansi is going to talk about.
Immediately, after the post-transplant period, now that your immune system is not well developed, or it's still the baby immune system, so you can have infections in the form of, you can have bacterial infection because you have a central line that we usually place in our patients who are undergoing transplant, because it just becomes easier for the patient, as well as the treating doctor to kind of give all the medicines to that. So infections in form of bacterial infections, your immunity is low, you can have fungal infection, you can have viral infection. That's why we keep these patients in HEPA filtered room. We have double barrier nursing. We take utmost care of these patients because we know their immunity is very, very less. We already talked about GVHD. They can be
No, that's fine.
sorry.
Sorry.
No, you can go ahead. Sorry. I just realized I was muted. Yeah.
And then, we talk about, when we are talking about some of the complications that can happen when we are counseling the parents, we talk about, like, any kind of organ toxicity can happen because of the medicines that these patients are receiving. So, for example, busulfan, Dr. Vikas has already said that, that can affect the lung. So that's one thing. There are other medicines that can injure your kidney, your liver. So all those things need to be kept in mind when we are doing a transplant for a patient.
That's right. I think the bottom line, what everybody needs to understand is that the common complications are infections, GVHD, rejections, and organ toxicity. So these are the four common complications which we as transplant physicians see in our practice. These are the acute complications. Then there can be late complications, or you can say complications which are happening after some time. You can have infertility issues. You can have chronic GVHD in a patient who has undergone a transplant. You can have problems related, autoimmune problems can happen. You can have dental issues, and very, very rarely you can have malignancies developing. So somebody who has got a radiation based conditioning, that's not commonly used in sickle cell anemia, but there are certain indications of using total body radiation based conditioning. So those patients are at risk of developing malignancies also.
Okay, thank you. I'll just go to Facebook now. We have a question on Facebook, and I've got a question from KD who says, is there a limit for somebody to have a bone marrow transplant? Can a 50-year-old or more have this treatment?
We are not the correct people to answer that. We are pediatric
Yeah,
hematologists.
pediatrics. Yeah.
To understand earlier, the better. I don't know at 50 years of age how good, bad your status is. I don't
Yeah,
know.
but with the children, up to what age would you be comfortable to say it's a good age?
Yeah, we've been pediatric hematologists. We see patients in the age of 18. So we have done transplant for an 18 or a 19-year-old person.
Okay.
Also.
All right.
But yeah, what we have to remember is, as we have discussed, the more you age with sickle cell, we know that they can be end organ damage. So that's why we say the earlier the better.
Okay. Now, are you comfortable to talk about the cost related, Dr. Vikas? If you can't tell us the exact cost, can you tell us like an estimate, including with if you come to India, for example, for 4 months, is it? What other costs on top of the actual treatment? Can you, whatever you're comfortable sharing?
All of you who are listening to us, you have to understand that transplant is never a package. Throughout the world, it's not a package. Bone marrow transplant is not like a kidney transplant or you can say a joint replacement or a angioplasty that doctor gives you an estimate and you will close in that estimate. So the tentative cost, what we tell these families for a matched sibling donor transplant is between 25 to 30,000 US dollars. So we need to understand what this 25 $30,000 include. This would include your 4 week stay in the hospital, your doctor fees, your transplant charges, your blood products, your antibiotics, and on top of that, for the pre-transplant workup, around 100, I would say 1,000 to $2,000 is what you're going to spend in the for the pre-transplant workup. And then once you get discharged after, let's say, 3-4 weeks of being in the hospital, you'll be coming initially twice in a week initially, and then we'll be calling you on a weekly basis. So in every visit you will be spending around $400, because other than doing a complete blood count, liver function test, kidney function test, we have to look at the immunosuppressive levels in the body. Let's say if the patient is on cyclosporin, that's a medicine for GVHD prophylaxis. So you need to check the level in the body. And another thing is that we commonly look for viruses, viral reactivations like CMV. Cytomegalovirus is a very common virus which reactivates after the transplant in a massive renal transplant. So these things add on to the cost. So if you are coming to India, you should have, I would say, for a massive renal transplant, anything between 45 to 48,000 US dollars in your pocket.
Okay.
Okay.
Thank you.
I have one more question. I think that there's so much focus on kind of the prep regimen and then the actual transplant itself, and there's not enough discussion around long-term follow-up care.
Mm.
And just personally, I'm not going to name any names of institutions, but where I was, I went 8 years with no follow-up care, no follow-up tests. And I talked to so many families and so many patients who go through this, and even for the ones that are successful, they have to adjust to a whole new life. Like they all of a sudden don't have this disease anymore. They don't, hopefully they don't need to take narcotics anymore. And then for the people that reject, they have to let go of that dream that they were going to be cured. And then, so that's psychological. And then physically, you have a whole different life too. So what do you guys do as far as long-term follow-up care? And how long do you typically follow your patient?
So, so we have already told you about the frequent visits that we do in the outpatient setting for the first 3 to 6 months. Following that, we ask them to see us at least once a month for the next 6 months, and then every 2 months or 3 months, and then yearly. So we do, yearly checkups after 2 years, because we know there are certain long-term side effects that we have to watch for. We do a physical exam. Depending on the age of the patient, if we need some tests or if we need, some other specialists to look at them, we do that as well. And it's usually yearly. And there are certain tests that we definitely do yearly to make sure all the organs are working fine, to make sure, psychologically they're at the right place where they need to be. Because as you've rightly said, majority of these patients, initially, we are all excited that, we are not going to be taking these medicines that we've been on for a long time. We won't have the pain crisis. We don't have to go to the hospital that frequently, get admitted for so many days, and get IV hooked up. But there are certain issues that are very specific to sickle cell patients that needs to be addressed at the right time. And transplant is it's a big thing. It's a life changing thing that we are doing. So yes, there are a lot of issues that need to be addressed, and we do that. One, depending on how well they're doing or how frequently they want it, how frequently the demand is from the patient itself, because we can see that, and then they will tell us how things are going.
Yeah, I think that's very important, and we see patients from different parts of Africa. So the majority of patients, if the transplant is going smooth, in the post-transplant period, there are not problems happening, and they go back to their home country, let's say after 100 days of transplant, we ask those families to bring us in contact with a local doctor, a good pediatrician, or a
That's good.
hematologist who is in the home country, so that they can follow with that pediatrician. Let's say every fortnightly they're getting the bloods over there, blood test over there, and they're sending those reports to us, and we're talking to the pediatrician or the hematologist. And then once, let's say the transplant is well, there is no GVHD, the child is well, after 1 year of transplant, we stop all the medicines, and we tell those families to come back to us at least once after 1 year of transplant. Come to us so that we can physically check you, we can get your bloods in India. We can do a heart echocardiography. We can look at the lungs. We can see the kidneys, how well they are after 1 year of transplant, and definitely we can counsel them about the immunization. So all of us need to
Yeah.
understand that if a patient has undergone a transplant, whatever immunization he has received in the past has all gone waste. So you have to
Right.
start a new schedule, and usually we start immunization after 1 year of transplant.
Okay. I think that's a very similar statement. So, well, daughter as well, up to 12 months, we stopped all the medications, and she's also done the transplants. Just with, I just want to do a comparison here because I'll leave some of the details. I think we're going to. I'll ask you offline. I want you to. I'm just seeing in the checks. Just maybe the person who put this question here about transfusions and bone marrow. So blood transfusion and bone marrow donation. Can you explain the difference so that people don't get confused? Like how this S. I don't know what your name is. So just explain because I've seen it in the chat. I'm sure maybe other viewers can also be confused that bone marrow donation and bone marrow transplant.
I read the question as well. I think what they're asking is, as a sickle cell trait, you're
Yes.
not allowed to give blood. You're not allowed to do blood donation.
Yeah.
But
Yeah.
as a sickle cell trait, you can be a donor. The
For the
reason
bone
being,
marrow.
correct, for the bone marrow transplant, a sickle
Yeah.
cell trait can be a donor because they're different things. When
Mm.
you're talking about blood transfusion or a blood donation, again, sickle cell traits because of the sickle cells that might go into the blood donation that you're doing. But when we are doing a bone marrow transplant, we are taking out your stem cells. We're not taking out the red cells.
Yeah.
We're
Yeah.
taking stem cells. And so that's why a sickle cell trait can be a donor for bone marrow transplant,
Okay.
but
Yeah.
not for regular blood donation.
Yes, yes, yes. So my question there, I think maybe the way I asked the question, maybe that's why they got confused. I was trying to compare that, with a blood transfusion, somebody who's an African ethnicity can get the blood from somebody else who's not African. So, because you spoke about how the bone marrow registry, we don't have so many Africans in that registry. So that's why that question came up. Well, thank you. I've got a question on Facebook also just about the age. What's the minimum age? So we spoke about the oldest, but what's the minimum age for somebody to have a transplant?
There's no minimum age. So we have done a transplant for even a 5-month-old baby.
Oh, okay.
So there is no minimum age. So if you have problems because of sickle cell, you can go ahead with the transplant.
Okay. All right. Well, it's almost 20 past 8. Unless anybody doesn't have any questions, we'll be wrapping up soon. Tiona, do you have any last questions before I ask Dr. Vikas just our last 3 questions before we wrap up?
No, I'm good to go.
Okay. Well, thank you so much. So this has been very informative. This, as I said, is very close to my heart, and I'm glad that you came in. I've also got people from Zambia because I'm from a Zambian background. So I've got my friends who wanted to hear this, and I'm glad that you came in. If there's any questions, again, we had Dr. Vikas all the way from India. He's a bone marrow transplant specialist. You can email me his questions either on Facebook, you can send them to Facebook, or email them to info@sicklecelltalks.com, and we're going to send them through. Otherwise, I'm back tomorrow. I don't have my flyer yet, and we're running out of time. I don't want to keep Dr. Vikas. Any of our guests today, do you have any questions before we go? And if you do, please unmute yourself. Looks like not. Well,
People have
I'll give you the last.
I'm saying people have understood each and everything, so they don't have any questions left.
Yes, yes, yes. I think so. Well, I always ask this question, Dr. Vikas. You are a bone marrow transplant, I know, and you are specialized in sickle cell. What message would you have for people who are living with sickle cell disease and would like to come and have a transplant?
Very important for all the families who have sickle cell anemia patients, that it's very important to have a good quality of life. So you have to give a good quality of life. Whether you give that good quality of life with blood transfusions, with oral medicines, or by getting a transplant done, that's your choice. But please decide among yourself how can you make your child not to suffer? All right, it's very traumatic to see these patients who come to us in bad shapes. I've seen patients having bad strokes in the past. I had a patient who was bedridden, had 2 strokes in the past, and the family contacted me from Nigeria, Dr. Vikas. We want to come to India for a transplant. We had a video consult, and the child was bedridden. So it is very, I would say, traumatic to see these type of patients. So I think it's very important for all of us to understand that if a child is suffering and we understand the pros and cons of the transplant, in our experience with a matched sibling donor transplant, the chances of mortality, or you can say what you call it, transplant rated mortality, is just 5% in matched sibling donor transplant. So 95% patients or 95% transplants go very smooth. So if you have, if you don't have financial issues, if you can arrange the funds and you understand that eventually what is going to happen to your child, nobody knows. Whether he'll have a stroke, let's say 2 days later, or maybe in the due course of his life, whether he'll have a complication later on, nobody knows. So if your child fulfills the criteria, what Dr. Mansi discussed in the indications of transplant, and you can arrange funds, and I would say, I'm not saying come to me, I'm the best transplantation in the world. I would say you should go ahead with the transplant because that's the only way to have a permanent cure.
Okay.
Right.
So, sorry, you spoke about the funds. I'll just throw it out there. Do you offer maybe payment options, like any options to pay maybe half and pay the other later or something, or you want it upfront?
No, no. So see, I'm a doctor. I work in a hospital. So the patient has to pay to the hospital, not to me. So when
Okay.
they come to India, let's say they pay 50% of the estimate given to them, and then before they get discharged, they have to clear the dues. That's
Okay.
very important. So in a month or so, in 1.5 months, they have to clear the dues.
Okay. All right. Thank you. Tiona, I had a question.
Not necessarily a question, just a statement, because like I said, I've kind of become the voice, and I kind of say the ugliness of transplants. Like, just because like I said, I want to be responsible with what we tell our families. And so I think, you guys stress the importance of knowing the pros and cons. And it's really important to weigh risk benefits, because I know of several patients who they were not satisfied with their quality of life with sickle cell, and they actually had the transplant, got cured, but then they ended up with another illness, and now they regret seeking out that cure. So I just think it's important that we stress the fact that you really do have to be aware of all the risk. And sometimes when you are used to suffering with sickle cell for however long, you get so blinded by the fact that you want a cure that you kind of don't really weigh the risks. I just think it's important to stress that.
No, I think that's really important, and the fact that you spoke about the mental health status of somebody, that you have to be psychologically prepared. I'm glad that you do involve the psychologists to prepare not just the patient but the families as well. So I think that's important, and to be just well informed that everybody should know what they are they are taking themselves into, and also that they should seek clarifications plus to know what they're going through, and even the follow-up is quite important. Yeah. Anyway, I think we are coming to the end of our session. I've just remembered, yes, I'm back on Wednesday. I've got a genetic counselor who's coming to do a session discussing genetic counseling in hemoglobinopathies. So I've got Caroline Cameron from the Monash Health coming on Wednesday. So please join us. But I would just like to thank you, Dr. Vikas, for accepting our invitation, and Dr. Mansi for co-hosting, plus Tiona, as always. Thank you so much for all the panelists who have come to join us. Again, I emphasize that if you've got any questions or clarifications, please do get in touch with us, and we are going to send through the questions to Dr. Vikas. Dr. Vikas, if you've got anything to say, you can. Otherwise, we thank you so much for joining us.
From our side, also from my side and from my colleague side, Dr. Mansi, I thank you for inviting us and making us a part of this meeting. And thank you, Tiona, for bringing the important things and important facts and the questions. And thank you very much.
All right. Thanks, everyone. Thanks, Facebook family.
Thank you.
All right.
Bye.
Thank you. Bye, everyone.
Bye.